All right, I think we're live now. Good afternoon or good morning, everyone. Thank you for joining us today for this important conversation on rural health transformation. We'll get started in a couple of minutes to allow a few more attendees to join, but we're glad you're here and we look forward to the discussion. All right, we're 2 minutes past the hour, so hopefully that allowed folks to join. And hello again, and thank you so much for joining us today. To kick things off, I'll briefly introduce myself. My name is Jordan Murray, and I'm the Associate Vice President of Customer Success here at Unite Us, and I'll be your moderator for today's discussion. It's an extreme privilege to be the moderator. I am a product of a rural community in small town Kentucky, and I'm actually in rural Missouri as we speak. So I will tell you, I've been spotty Wi-Fi a few times today, so I apologize if that happens, which hopefully isn't the case. But as just for a few housekeeping notes before we dive in, we will be monitoring the chat throughout the session, and we reserve some time at the end for Q&A. We have some great panelists, so if we don't have time for the Q&A, we will definitely get back to as a follow-up. So please submit your questions in the Q&A box as we go, and then we'll also answer as many as time allows along the way. You'll also see in that same box, there will be a survey pop up throughout for 3 survey questions, and we'll periodically ask for your feedback for those things as well. So the topic for today is around rural communities, and we know that they've always led with innovation and collaboration, really long before new funding opportunities were announced. Organizations have really been building strong partnerships to improve outcomes and meeting their real needs, rooted in the communities that they're serving. So as rural health transformation program initiatives continue to take shape, we know organizations are focused on scaling what is already working while preparing for new funding requirements, policy shifts, and accountability expectations. Each sector is experiencing the moment differently, though. Government agencies are thinking about oversight and funding flow. Payers are focused on outcomes and sustainability. Providers are looking at integration and workflows. And we can't forget about the community-based organizations who are planning for capacity and long-term stability. So today we'll talk about how rural leaders are demonstrating measurable impact now and how they're aligning strategy, partnership, and infrastructure for what's next. So while we wait for a few others to join, I'd like to invite you all to answer the first of 3 poll questions, which will be in the window to the side of your screen next to the Q&A box. And the first question is, what are you hoping to learn today? So as you all fill that out, I would also like to get us started by taking a moment to introduce you to our stellar panelists who are leading this work across the country. We have with us today Amanda McCarthy, Director of Social Determinants of Health at Advanced Health in Oregon, Dr. Paula Masters, Chief Health Disparities Officer at Ballad Health in Tennessee, Dr. Laurie Stradley, CEO of Impact Health in North Carolina, and Justin Barnes, Program Supervisor at Calaveras Health and Human Services Agency in California. I do know Dr. Masters is having a little audio-visual challenges, so hopefully she'll be able to join us shortly. But again, thank you all for being here, for your leadership and really what you do in your communities. So with that said, let's go ahead and jump on in with the first question. To ground us all in your work, would you mind sharing more about the community you serve and what makes it distinctly rural? And if you don't mind, Amanda, we'd love to start with you.
Yeah, thank you very much. Advanced Health, we are a Medicaid coordinated care organization, and we're serving the Southern Oregon coast. We serve about 26,000 lives in both Coos and Curry counties. We are considered rural frontier, and we cover about 3,200 square miles. The coordinated care is an effort for Medicaid members to make sure they're receiving um, physical health, behavioral health, transportation, and other services, including oral health. And we do experience challenges in the areas of access to care, especially when it comes to time and distance standards and specialty care. And we also have transportation and general poverty or generational poverty here in our area as well.
Thanks, Amanda. How about yourself, Dr. Stradley?
Hey, good afternoon. Lori Stradley, and I serve as a Chief Executive Officer here at Impact Health. We're based in Asheville, North Carolina, and serve the 18 to 19 westernmost counties of the state. North Carolina has the second largest rural population in the country, and a third of those live out here with me in the mountains. Even though Asheville is not where I was born, I also am a product of a rural community. I grew up on the other side of these mountains, all the way up in northern New York in the Adirondacks. And it's a great privilege to get to do this work here in the mountains where my husband and his family were born and raised. And when I think about what we're doing, Impact Health is predominantly a bridge. We're a social care hub that works with community-based organizations across the region. And we work with healthcare and payers and all other types of folks to try and make it as easy and cost-effective and outcomes-driven as possible to ensure that folks are having their complete care needs met, from clinical and behavioral health to social care like housing, food, transportation, and including family safety. So that has been a part of our work here in North Carolina, helping individuals transition out of homes that are experiencing violence. Just to add a few things, I would say, with respect to the challenges that we're facing here, I would love to say they're unique, but I don't think there are that many unique challenges anymore in rural care provision. You've already brought up, Jordan, that access to broadband is a real driver of health out here, and the same places that are really far from a healthcare system are really far from broadband access. And so a lot of the solutions that have been applied around virtual care and sort of home-based care really a struggle out here in Western North Carolina. But our opportunities are even greater. We're really optimistic about what rural health transformation can mean. And for us is particularly about building the most resilient systems possible during a time when healthcare spending, programs and interventions are really volatile. They're changing every day, some for the good and some are much more difficult changes to face.
No, those are some great points, and I appreciate you sharing that. I think that'll lend well into the following questions as well. I see Dr. Masters, you're able to join. Thank you. Hopefully the audio visual is working now. And really just to remind everyone of the question here, to really grounding us in the work, do you mind sharing about the community you serve and what makes it distinctly rural?
Yes, and hello everyone. So sorry for my issues, but I'm happy to be on. But yes, so I'm the Chief Health Disparities Officer here at Ballad Health, and Ballad Health is one of the largest health systems in the area. So we serve 29 counties across 4 states and primarily 21 counties in Virginia and in Tennessee. We are right in the middle of Central Appalachia. So when you say rural, that is exactly what we are. And so, when we think around what it's like to have a health system that has 20 hospitals and over 13,000 team members and 800 providers, and where we really have been on the journey to not just be a traditional healthcare delivery system, but to really be a community health improvement organization. Trying to figure that out here in this community is something that comes with its challenges, obviously rurality, but the other elements that really come into rural. So, those things around lower socioeconomic status, those things around the fact that every one of our counties that we serve is either a medically underserved area or a health professional shortage area, or both. And then just thinking about, really those social drivers of health that even make things more complex in really being able to improve the health and outcomes and well-being of our rural populations. I like to always tell people that, where we are, we've always had to figure it out. And now everybody is definitely trying to figure it out. And so we're really excited that there is a lot of attention now for rural outcomes and that we're all actually networking together to have some really collaborative solutions. So happy to be here.
No, thank you so much, Dr. Masters. And to continue to go back to the West Coast to Justin, would you mind sharing your perspective as well?
Yeah, of course. Thanks for having me here, Jordan. So I know a lot of people, when they think of California, they probably don't think of rural America necessarily, but in California, we have rural communities as well. I work for Calaveras County Public Health, which is housed in our County Health and Human Services Agency. Calaveras is a small county in Northern California. We have about 45,000 residents located in the foothills of the Sierra Nevada mountains. Our community is demographically a little bit older. About a third of our residents are over the age of 60. We have about 9% of our population are military veterans. And I think you're going to hear some recurring themes in this webinar, and ours is certainly our challenges related to healthcare access. And one of the things that plays into that healthcare access issue is transportation access. Calaveras has extremely limited transportation infrastructure. Less than 1% of our residents utilize public transit because it's just not something that's actionable for them to do. Additionally, we have about 2,570 residents for every one primary care provider in our county, and about 2,250 residents for every dental provider. So that's just to paint the picture of, we have way more people that need care than we have providers capable of bringing that care to our community. So we at Public Health are always looking at addressing those social drivers of health that Dr. Paula Masters mentioned, because obviously those are driving the health disparities in our community, which are leading to the downstream consequences when access to care is limited. The long and short of it is, when you have to drive 3 hours to see a specialist, you're probably not going to see that specialist. And we're hoping with rural health transformation and some of the things we're trying to do here at Public Health, we can ameliorate some of those barriers and improve access to care.
No, I appreciate that. And I think we can all agree the commonality, despite where you may be across the country, the rural communities are impacted very similarly just to some of these barriers. So before we move into our next panel question, we'd love to hear from you again. So on the poll, where is your organization in advancing rural health transformation efforts? And to build on that, we know that rural communities have not been waiting for transformation funds to really begin that innovation. So I'd love to turn it over to our panelists to really discuss, how are you currently supporting the rural populations in your regions? And if we don't mind, Dr. Masters, we'd love to start with you.
Yeah, happy to. I think that's exactly right, is that, those of us that have been working in the rural areas, for a long time, is that we've made it work for a long time. And so, I think that it really leans into those things that always hold true, is that while we're rural, is that we're very resourceful, we're very collaborative, we're very resilient. And so, we've set up a lot of infrastructure, just, I'm sure all of my colleagues have, to be able to be ready for, for anything that really is thrown at us. And I think that, one of the biggest things that we have done here in our area is exactly that, is, being collaborative. How do we create a different infrastructure and architecture here to be able to solve for the access issues, to really be able to bring down innovative and different reimbursement models, to really set up different systems of care that include that social care piece, that those social drivers of health. And I think, one of the things that we have really done over the past 5-ish years, if you will, is to have an evidence-based model for collaboration. So we've leaned very heavily into the collective impact model, and being able to, that it centers around 5 things: a common agenda, a shared measurement, mutually reinforcing activities, open and continuing communication, and then really having some strong backbones. And Ballot Health, we serve as a backbone to one of the largest collective impact models. It's called a strong accountable care community that crosses the states in which we work. And what that has really allowed for us to do is be able to be more intentional with how we collaborate with community-based organizations and how we better network them together and create that common agenda and those mutually reinforcing activities. You know, we've been able to use and leverage that network of community-based organizations to really have a community prong to our social care strategy. And that's so important in rural areas because we don't have all of those resources. We don't have all of the technology and all of the bells and whistles, if you will, that a lot of times lend themselves in other areas. And so being able to be very intentional in your structure is something that we really have leaned into. And, you know, for us, a big part of that has been being able to bring different data and technology in. And so we, over the past 5 years, has really worked hard to create a different infrastructure here in our rural area. And so, you know, Unite Us has been a big part of that, is that we in our health system, we use Epic as our electronic medical record, but, you know, we also needed that social record, and that was a first of its kind in this area. And so being able to have that and come in and be able to have it truly integrated, not just sitting on top, and then bring that to our community-based partners, so that way it helps for them to solve for issues that they're having as well. Because what we may be experiencing from the health system side or from the healthcare side is that our community health partners, our public health partners, our social service partners, they may be looking at different issues or different, not just different issues, but ways to address those issues. And so being able to have a coordinated solution is something that, you know, it has worked really, really well for us. And, you know, I think being able to demonstrate results from that is something that we've been able to talk about a lot recently. But definitely, I'll pull up there and let my colleagues weigh in on that. But I think it's definitely around that evidence-based, that architecture model that allows for intentional collaboration is how rural areas are really set up for success.
Yeah, no, I appreciate it. And, you know, I love just like the emphasis on the intentionality of the architecture and the structure. And you start to think about the program design on the front end is really going to dictate, are you positioning your programs to capture true outcomes versus outputs, which we know really doesn't move the needle. You know, to continue those thoughts, I'd love to pass it over to you, Justin. You know, what are your thoughts on that?
Yeah, it's an important conversation, and I think Dr. Master spoke to this a little bit. One of the strengths of rural communities is our ability to forge relationships, right? That's sort of when you think of rural America, a lot of people, it kind of evokes images of tight-knit relationships, small communities, people know each other. You went to high school together, you have those relationships, and you can build on that. And that's what we see at Calaveras County Public Health when we're looking at building relationships to coordinate across sectors, is leaning into our strength as a rural community by tapping those personal relationships we have with different providers across different sectors, our CBO partners. And that's where Unite Us was very useful to us, is it gave us the infrastructure to finally have something concrete that does connect us all and give us the ability to ameliorate those access gaps. One of the sort of innovative ways we've looked at improving access to care is we have a mobile programs and services van, which is something we're seeing across California in general, ameliorating that transportation barrier by bringing the services to the communities that need them instead of expecting them to come to us. And then when we're able to get to them, having something like Unite Us in place, where now we're able to not only screen them for chronic disease, identify what issues they may be dealing with, and then getting them referred to our partners across different sectors, whether it's social determinants of health related resources or healthcare related resources, getting them connected to care. And most importantly, now we have the outcome of that. We have the data to kind of support what's going on, how that's working, where the deficits are, which is definitely placing us in a better position to be more agile and to go after other opportunities that come along the way. You know, rural health transformation is huge. and we're going to seize the moment to the best of our ability. But there will be other opportunities down the road, and what we build with RHT now is going to inform how well we're able to access those future opportunities that will inevitably come. So that's kind of what we've been looking at, coordinating across sectors to make sure our partners see our vision, get on the same infrastructure as us digitally, which is very new to Calaveras County. That was a lot of conversations and a lot of kind of education on why that's important, why that's needed, because in a lot of rural communities, there's this thing where things have been working a certain way this way, and we're going to stick with that because that's what we know. And sometimes it's tough to put something new and innovative out there and sell all your partners on it, but that goes back to having those strong relationships, being able to show them the outcomes and how that can benefit the people they serve, and then everyone seems to benefit.
No, I love that you pointed that out, right? Like the change management aspect here is steep. And again, like a lot of that can't even be started without that human component, right? That human to human component. So would love to kind of, continue those thoughts. Like Dr. Stradley, how would you kind of, from your perspective, share in your region?
Yeah, I really appreciate both Dr. Masters and Justin how you're framing up the relationship side of it, because that is definitely where it all starts out here in Western North Carolina. Is that, I mean, even in every meeting, you sit down and figure out who your people are and how you're connected, and who are your people is one of those questions. And it doesn't always mean your family. It can be anything, but creating relationships is at the base of everything that we do out here. And building trust too. North Carolina is a really diverse state geographically, economically. And so if you're not grounded in Western North Carolina, you're an outsider, and it's really tough to break that. And so one of the ways that at Impact Health, what we really try to do is find the safest places for people and build trust with them. So to sort of go backwards a little bit and how we have been doing work in rural health for the last 5 years and how that's prepared us for this transformation work, is to talk a little bit about North Carolina's 1115 waiver. And that the 1115 waivers, I think you probably all know, are ways to let us demonstrate and test out new models for leveraging Medicaid dollars to get better health outcomes at lower costs. And in North Carolina, ours was sort of a three-prong approach. We moved to a managed care model. We implemented a tailored plan model, which supports folks who have much more complex healthcare needs in the Medicaid framework. But the piece that I worked on the most was called the Healthy Opportunities Pilot. And that gave us a chance to look at 29 services, social care services between food, housing, transportation, family safety, to really test the waters. One, could we even stand this up? Was it possible to create a system that could effectively refer, complete services, bill for those services, track them, and follow the outcomes? Could we even do that? And thankfully, the answer was a resounding yes. Of course, we couldn't have done that without partnership from Unite Us, who created the NC Cares 360 platform in North Carolina. So not only did it have a referral system, it also incorporated the billing aspects of the work that is important for our community-based organizations to get reimbursed for that work. But Medicaid is this big state and federal program that doesn't always engender trust in communities when you hear that sort of big name. And so really quickly, we moved to what we call the no wrong door approach. So if somebody is already coming into a food bank and, let's say they haven't seen Miss Sarah for 3 weeks. And so she finally comes back and the person working at the pantry says, "We haven't seen you in a few weeks. What's going on?" And Sarah says, "Well, I have a flat tire and I haven't been able to get here to get my food box. It's been an incredibly hard 3 weeks." And after a little bit of discussion, that food bank may say, you might be eligible for some support, either in transportation or food deliveries. And so that is how a lot of our rural community members got connected into this Medicaid resource. They might already have Medicaid and get screened into Healthy Opportunities, or they might be eligible for Medicaid and start there, so they now start to get clinical care as well. And originally when North Carolina launched that program, it wasn't intended to be a rural health strategy, but that is what it became, because we are operating in 3 regions across the state, and all 3 of those are predominantly rural. And that let us build the foundation for how North Carolina is intending to operate the Rural Health Transformation Program with this local hub model that is deeply embedded in community, partnered with the state, partnered with payers and clinical health systems, comfortable with all of the variety of technologies that are going to be necessary to do this, ultimately with the goal of making sure that everybody gets to do what they do best. We don't want our community-based organizations bogged down in billing and negotiating value-based care models and all of that. We want them in relationship, identifying food sources, getting them out the door, building community. We want our payers focused on the best, most innovative funding structures to make sure that their folks are getting great health outcomes. And we sit in the middle of that to try and make it as easy as possible to have this all happen. And again, with our rural health initiatives prior to this funding, we were able to show that having a local partner who is connected in all these ways makes it easier for everybody to get the work done, to track it, and to tell the story. And we're really proud to be a part of it, and to recognize again, the reason we do it this way is because Western North Carolina looks very different from the Piedmont, from the East Coast on the ocean, and we just have very different needs. I know I said at the beginning, we have a lot of rural health in common, but we have different cultures, we have different food preferences, we have different local foods, we have different ACC affiliations. We always have to say that during March Madness. So it's really wonderful to have those local groups, and then for us to get to work together so that we can roll that up into a statewide picture that allows for better investment in the gaps and service needs across the state. And that's another place where Unite Us has really come into play for us, is that if each of the regions are tapping into these resources, we can really look at a regional and state level on where we're providing services, where the gaps are, and how we can do it as effectively as possible. Because with the way healthcare budgets are right now, there is no room for double spend or overlap between services. We have to be precise in the way we're delivering these resources.
Yeah, no, I think you're absolutely right. And one big takeaway that I had from that is obviously all of the differences that occur throughout that regional kind of, makeup, all the rural environments are different. And the way that you leverage the technology and infrastructure is going to be different based on the needs of that local community, and having that convening entity to bring everybody together, again, to that human element. And that's where the technology can really help support the follow-on activities. So I know Amanda had to step away real quick, so we'll jump to the next question. And I do want to share, from the last poll, the top answer was a majority of the folks here are actively planning or building partnerships, with a secondary answer of scaling or expanding existing work. So you can see, most of our listeners here are really on the cutting edge of what can they do to get started. And as we've talked about the many moving pieces, with Unite Us just being one part of the broader ecosystem, as really these new funding opportunities emerge, how is your organization preparing to play a role in the solution? And if you don't mind, Justin, I'd love to start with you.
Sure. So one of the main ways we're looking to be part of the solution is by looking at our existing partnerships and seeking to expand further. This is a huge opportunity for rural communities, and the best way to truly operationalize these resources, this funding, this opportunity, is everyone has to be at the table and have an understanding of the needs of the communities we serve. To Dr. Stradley's point, the varying needs too. I mean, I could say, I'm not talking about our whole state necessarily. Even in our small community, we have differences from community to community that we have to keep at top of mind, and we have to tailor how we approach our services to them. And that idea just kind of compounds with the greater scale you have. And so along with that, the scale of your partnerships has to follow, because those are your subject matter experts that are going to be able to give you that vital information on how to best operationalize this RHT to reach those communities. None of this matters if we can't reach those highest need communities, and I am not able to access every single high need community we have. So having all our partners at the table is huge. So we try to meet early and often with our partners to understand, I was talking to one of our managed care plan partners just the other day about Medicaid, we call it Medi-Cal in California redetermination, and how that's going to affect our communities. And, it's trying to stay on top of these rapidly evolving changes. And the best way to do that is to have everyone at the table and have conversations about it as often as possible. We're also looking to improve our data and reporting capabilities to just stay agile, stay on top of this kind of ever-changing environment that we find ourselves in. One of the big hurdles that I think many rural communities face is capturing that relevant data, capturing what's going on to be able to actualize the resources we are getting and use them in the most appropriate manner. I think we've all heard, I know I've heard many stories, many anecdotal tales of struggles to access, people missing appointments they desperately need because they can't afford the gas money to get to a provider. They're having to make those kind of decisions. Do I go to get specialty care, or do I have enough money to go to work the day after? And having issues accessing food sources, housing, mental health care. But historically, particularly in Calaveras County, we've struggled to have the data infrastructure and reporting capabilities to capture those stories, translate them into data, and then use that to access opportunities. So I think an opportunity like this comes along, and in my mind, when I think rural communities, I think improving our ability to turn those stories into data points that we can then operationalize to find the best way to serve our communities, to stay on top of their needs as they change, and to access future opportunities down the road. I think if rural communities can lean into improving that capability so that the story of our health disparities has more granular detail, because I think a lot of times we have some kind of high level outcomes, we know access is bad, but why, and what are the sort of nuances between populations? Historically, we just haven't had the resources to get that granular with it. And it's very hard to turn that into tangible change when you don't have the detailed granular information to work off of. So we have an opportunity through rural health transformation and working with organizations like Unite Us to kind of break out of this feedback loop of we can't get data, so we can't access opportunities, so we can't get data, and we're just stuck in that. And this is our opportunity to break out by accessing this funding, by working with our Unite Us partners, having that cross-sector collaboration to make those tangible improvements in health disparities that we've seen for many, many years in rural America.
No, I appreciate that, Justin. I think some things that stood out to me really is like leveraging data and infrastructure to be able to tell a true story, and not just a story of it makes you feel good, but also like real impact and value. So I'd love to direct you all to the documents in the right side of the, those are a lot of case studies. And I think that's something that, we really pride ourselves on, is empowering our partners to take that data and insights and show real ROI and impact so that we can then scale it. Because that was another piece that I heard you mention, is like the challenges in scaling. And we know that we're 6 months into the first year of the 5-year health transformation, and they're just now getting, things rolling. So I think, thinking about the challenges in scaling, I think Dr. Stradley, I think you have unique perspective given your experience with healthy opportunities. So like, just to go back to the question is, with all these new funding opportunities, how is your organization prepared to play a role in this solution as well?
Thanks, Justin. I really appreciated what you said about the data infrastructure, because that is absolutely a priority for us for rural health transformation in the region. And that was one of the missing pieces, or just really disconnected pieces of the Healthy Opportunities pilot, and our ability to tell that story clearly for our legislators to make good decisions about funding. There was a huge amount of data, but the connections between them is really where we're struggling. And so that's one of the ways that we hope to use the rural health transformation funding. And, it really also speaks to our intention to build on what works. Now is actually, it's not necessary for us to technically innovate. We know what works. We know how it works. And now is the time to sort of more deeply invest in what works. So the innovation is probably alignment and connectivity and transparency. When we do this work, a lot of us have to come together in spaces that would sometimes be competitive. Even the process that we're going through right now in Western North Carolina, trying to identify who that hub is, has been really interesting. It's been a 4-week turnaround to identify the hubs in each of the 6 regions in the state. And I was speaking with a healthcare executive earlier this week, and he said, all the conversations I have, I feel like if we had 4 months to write this application, there would only be one from our region, because we really do work together that closely. We don't intend to be competitive, but in some cases it becomes competitive when it doesn't need to be. So if we could build this better infrastructure, share data more transparently, make the right investment at the right time, then all of us become more sustainable in the long-term investments in rural health transformation. So those are really my two highlights: is build on what works. North Carolina is going to receive up to $213 million annually for 5 years. And one of my friends, who is a former Medicaid director at a state, says that's Medicaid dust. It's hardly anything relative to the whole big picture of Medicaid spend. So we have to be incredibly intentional in how we invest that money, or it could get swallowed up by other interests that are not as deeply embedded in community. So, keeping those connections alive and making sure that we have we speak with one voice, and we do it very clearly based on the data that we have really brought together, and to make it useful data. So one of the areas of bringing those threads together is to make sure that everybody has access to multiple layers of data without having to visit 7 or 8 different platforms. Because when you're talking to a primary care physician, who really should be the medical home for an individual, especially in rural spaces where access to other layers of care is more difficult to come by, they need to know that referral for a food box, that loop closed, and that the family is receiving it. They would already know if that MRI they sent someone off to get came back. That system has been around for a long time, but we need them to really trust the social care systems and make sure that data is actually getting back to the people who have the opportunity to shape the health outcomes of these individuals.
No, that's great. And I think, we're seeing the consistency, right, of like the data is incredibly important, but like, how can you make the data actionable, right? And again, I think as we, our proud partners on the steering committee of the Gravity Project, more standards based around this space, and just a continued evolution will create that ecosystem for more collaboration and not competition, right? We're honestly, with rising tides, all boats will rise, and really looking forward to how that continues to evolve to really serve the communities at the most. So to turn to you, Dr. Masters, I guess with all these new funding opportunities, like, how are you all prepared to play a role?
Yeah, absolutely. I think that, being from the health system is just like Dr. Stradley had said too, is that, being very collaborative. And I think that for us, it was really being able to understand what role we needed to play, because I think that it looks different depending upon what we're trying to accomplish with these dollars. In some of the areas, we may be the quarterback. In other areas, we're not. And really being able to have a model that works for that to just be organic, to be intimate, and to be successful. Since all of this has come about, we've had, just like Justin was talking about, we've had so many meetings with so many different partners to try to get everybody on the same page. And realizing too is that we need to be all at the table, all one voice, but we need to be very specific in what we're all trying to accomplish and what we're all trying to say. I think that's the biggest piece that we have really been seeing. I completely agree that we're trying to, it goes back to where we started this conversation. Rural has been figuring it out for a while. We already knew that we needed to have very individualistic, customizable solutions. We needed to have it based on evidence. We need to have it based on what works. So now it's not that we're innovating, it's that we're optimizing, it's that we're scaling, and it's that we're doing it together. Because you're right about the all boats, is that we don't want anyone to be left behind. We don't want to further marginalize our already vulnerable populations. And so being able to really do that. So that's where we're really leaning into. Completely agree about data and infrastructure and technology, and really thinking around a systems approach. How do we get more interoperability? That's the one thing that I would add on there for this, is that it's one thing to have this great technology over here and another data system over here, but it doesn't do anyone good if they don't talk to each other, or that we don't have the right agreements in place for them to share. Because I think the other thing that we're going to have to solve for is to allow for bi-directional sharing of data and information, because social service agencies have great data, community-based organizations have great data, health systems have great data. Where does it come together to tell the true story? And I think that's the piece, is like really looking at, and how do we play a big role there is what we have really been leaning into, and really looking at added capacity for each other, is that I don't have to do all of these things because I have great partners. And how do we create a completely different continuum of care, to where there's no blips, there's no barriers between the clinical care to the physical care to the spiritual care to the social care. And I think that is where we lean into what we all have seen as what works and what role we need to play in it.
No, I love that, right? Like, it's not about like just the innovation, but like, we know what works, and it's like, how do we go ahead and lean into scaling and optimizing? I'm going to steal that. So, but I will give you credit, Dr. Masters, when I use it elsewhere. So, I mean, just for the sake of time, obviously, Amanda, glad you're able to join back with us. We'd love to lead off with the next question with you. Really, I mean, this is a really exciting moment, right? Like, we know it's a tremendous opportunity. So really, I guess, where do you see the biggest opportunity in your community, in your region, and then also nationally with the rural health transformation?
Thank you. Can I hear a part of that question one more time? I'm sorry, it cut out on me.
Yeah, no worries, not at all. I guess, what excites you the most about the rural health transformation? And like, what do you see as the biggest opportunity, not just for your region, but also nationally?
Yeah, thank you. So our community has been, like others here, working to try to figure out what sustainability looks like for traditional healthcare workers and community health workers, and how to really increase access to those services for our population. There's such a need for navigating through not only social services, but the health services in our region. And so I'm really excited about some of the changes we've seen to the oversight model for those mid-level community health workers, and how we're able to actually add more to our network and increase that access for our population. It really opens up, and then if they're able to bill for it, then they can be sustainable. And so we're seeing these little community benefit organizations that are rooted in faith-based, or they're rooted in culturally specific organizations, be able to stand up programs that help community members really navigate through the services, and then they're actually receiving funding for that to sustain the program internally. And so it's really wonderful to see them not have to work so hard to try to figure out how to financially sustain themselves, and because those smaller community benefit organizations are able to play in the same area, they can bring populations that we haven't seen to access those services as well. And that's been really great to see here in our local region. And then I think that same thought just kind of nationally, and watching the smaller grassroots organizations just, stand in the spaces they've never been able to stand before, because they're able to be sustainable.
Yeah, like I want to thank you for pointing out the community health worker approach, because like, as you think about that, right, you can again direct everybody to look at the documents. The Ballot Health case study actually articulates the ROI on folks in the community getting connected to care through community health workers, knowing that they can look at their entire holistic health journey, social and clinical, to optimize their experience. And I just came from the Missouri Community Health Worker Association conference, where we actually presented on that case study, and it was a packed room. And it's something that just validates not only what can happen and have an impact on the regional level, but on a national level as well. So with that said, I mean, would love to pass it over to Dr. Stradley. With everything that's coming down, what most excites you about this rural health transformation?
I think it's this unified focus on rural health. So, as I think about the work that we've all been doing for generations in most of our regions to try and sort of crack this nut to make sure that people who don't want to live in cities still have access to the things that they need to thrive. And it's sometimes a matter of making our own connections and running into somebody at a conference who is working on the same thing you are. And so now this sort of uplifted national conversation, I think, is going to allow us to accelerate. And Dr. Masters, I am also going to be stealing that optimize instead of innovate. It's just exactly right, because the innovation has been unending for a long time out here. So I would say that's the thing I'm the most excited about, is to really highlight this opportunity and bring us together, and to bring, honestly, more folks into this who maybe didn't know that they could have an impact or be a part of it. So that's the broader level. And then the other piece is the investment in exactly, what you've mentioned. Our community health workforce has sort of been behind the scenes for generations. And really in North Carolina, we were able to make a deeper investment in our community health workers during COVID. And that really lifted up this recognition of the, there's medical value. It feels really tangible to say that, but also the care and comfort and really seeing people that comes along with community health workforce. So that's my really high level and my really in the weeds folks who know how to care for each other. Those are my really two things that I'm so excited about for this.
Awesome. I appreciate you sharing your thoughts. And yeah, I think, again, continued alignment with everybody here. I really appreciate your perspective. And again, for the sake of time, would love to just kind of go into the final question. And obviously, Justin and Dr. Masters, please share your excitement too, and your last response here about what's most exciting. But as building on all of this, many of you are actively thinking through strategy, funding alignment, cross-sector collaboration. So what advice would you offer to organizations preparing for rural health transformation in their own communities? And I guess I forgot to ask the last poll question too. So I'm going to pivot back for a second. Also to the attendees, we'd love to still hear from you. And really, what are your biggest challenges? Because I think it's going to still provide insight as this is continually optimizing, not innovating, to continued improvement. But anyway, Dr. Masters, to again restate the last question, I apologize. As you're thinking about strategy, funding alignment, and cross-sector collaboration, what advice would you offer to the organizations preparing for rural health transformation in their own communities?
Yeah, I think that is, I think that's such an interesting question, right? Because we've been doing this for a while, and I still seek advice from everybody else. But I'll give just some thoughts, and I think it really leans into a lot of the things that we've been talking about. Is very much of what has worked. So really looking into what has worked and really thinking about it from a different piece. You've heard all of us talk about, the data and telling the story. And what I would say is that really look at the difference of the value equation in which you're communicating and making sure that it's always numbers and people and numbers. And I think that's a big piece. You talked about the case study that, we were part of. We saw that demonstrated. And so we're going to be very much leaning into that. I think the other element that, I would add on to that is allowing things to be okay with being data informed and mission driven. Those things are not in opposition of one another, but a lot of times we allow ourselves to be okay with somebody telling us that it is. And I would say, no, it's not. And that's where that's where that optimization really comes into play, and allowing for those things to be community derived and community driven. And I think the last one that I would say, and I think it just, again, underlines what we've been talking about when we're talking about collaboration and being intentional, but really being okay with getting outside of your walls and getting outside of your box, and being able to get with folks that are doing this work that may not be doing this work exactly how you would see it done. I think I've learned some of my most important lessons and some of the most useful pieces for community health improvement and social care integration from those partners that I just happened upon versus being intentional and going and talking to them. So that's the advice that I would give.
No, I appreciate that. And how about yourself, Justin? What advice would you recommend to the organizations as rural health transformation gets it well underway?
I think one thing that's important to keep in mind during these times of transformation and change and being able to access more resources and do more is to not reinvent the wheel necessarily. We've been talking about how we've all seen in rural communities all across the country for many years that, rural communities figure it out. They find ways to make things work. They've found models that work for their community, and they found ways to implement those models with very limited funding, resources, staff, and capacity. So now that we have all this, now we have access to more of these resources and we can do something that is hopefully transformative. It doesn't mean we have to invent something brand new out of whole cloth. I mean, one thing I love doing is I love stealing ideas. Frankly, I love seeing what professionals like the people on this panel are doing, and I pull bits and pieces out and I try to build it into our programs, our services, our policies that we offer to our community, because they're battle tested, they work, they're evidence based. The evidence is speaking to professionals like we have here, hearing how they implemented it, what challenges they ran into, being able to have that information at the forefront and plan for it ahead of time. And I think that's why it's important to have all your partners involved too, is they know things that work and they know the mistakes to avoid. A lot of times you don't have to ask people like us. There's people in your community that can tell you the mistakes to avoid. You got to listen to them, and I think sometimes people forget that. And I think the other part of it is bringing the community along for the ride. I think we talk about cross-sector collaboration and working with our partners and CBOs and these large systems, but this is all to serve the broader community. That's what all this is aimed at. And if they have no way to be a part of the conversation as you build systems and scale up, there's going to be gaps. You're just going to miss things. It's inevitable. If one thing we talk about in public health a lot is things like community-based participatory research, and the whole crux of that is bring the community along for the ride, center them in all the conversations, and kind of let them steer the ship to the degree that's feasible and possible. And you'll naturally avoid a lot of mistakes because they'll tell you what they are, and they'll tell you how they happen, when they happen, what they look like, and why it drives them crazy. And then our job is to take that information and actualize it in a way to make our systems work better. So that would be my advice from my perspective.
No, I love that. And that, coming off the heels of the conference I was with one of our Missouri Torch Hub partners, and that's exactly what they emphasized: the importance of giving the community-based organizations a seat at the table, and really that collective, really effort, really you're able to learn from everyone else's, history and experiences and, mistakes, for lack of a better term, and really continue to innovate. How about yourself, Amanda? What most excites you, and what would you recommend as far as advice to the organizations around rural health?
Yeah, thank you. I think that I always try to start with the end in mind. So what am I actually trying to accomplish, and making sure that, I have the right people at the table. We're bringing the community into the conversation. And for Medicaid, it's our members, right? They will, like Justin said, they're happy to share with us the things that they are passionate about and the things that they're very much against. And so, a lot of really saying the same things, and understanding your partners and where they are. Are they able to take on a new technology? Are they able to stand up a new program? Where they are, and understanding what their barriers are will help us all come together and build something that actually will last. Instead of rolling it from the top down and saying, all of these organizations have to do all of these things. So really just understanding who your partners are and where they are in the process, and really where they best fit into the build of any programming.
Yeah, and that's I think the emphasis, and it really talks about, we discuss like program design, like being so intentional, and you think end in mind first. That really, I think, helps in your shaping of that. Dr. Stradley, I kind of, obviously want to piggyback on, what advice would you recommend, but from our poll question, we did see that, some of the biggest challenges are partner alignment and then funding and sustainability. Given your experience with Healthy Opportunities, what advice, with those two things in mind, would you give the organizations listening today?
Yeah, I saw the question there that we're not currently funded for Healthy Opportunities, and that's true, but we are still operating under the 1115 waiver through 2029. And so we're still having great conversations with our legislators, and there's a recognition that this program is working and it's time to refine and focus it. So I am optimistic that we will get that done. So to that point, it is important from day one to engage whatever funding streams you are working with in your work, not just sending reports and giving updates or publications, but inviting people out into the community, inviting them into spaces where lives are being changed. So tell your story from day one. Don't wait until you have outcomes, because the process matters too. To put a fine point on some of the pieces that have already come up about making sure you're maintaining relationships and not disrupting them. If you find yourself in a room talking about a health outcome that you intend or a program intervention that you want, and the people being affected by that, there's no one in the room from that community, stop what you're doing. Wait, get those folks reconnected. There are so many quiet things happening in your community that you may not know about unless you are of the community. And that can be very specific. It could be broadly farm workers, or it could be Spanish-speaking farm workers. So like getting narrowed in on where the intervention is really matters. So you have to create space to be wrong and to stop and to engage people. Otherwise, you absolutely will disrupt, because this is a really fast moving intervention. There is expectation that we will move to action quickly. This is not a planning investment. And so, being willing to acknowledge a mistake, repair it, and then get back to work together is really my advice for how we can do this well. Don't be afraid to say, oh, I missed that one. I am sorry. There's no room for defensiveness or, refusing to hear what people have to say. So we're really excited about that. And that's definitely a core value of Impact Health, is that let's talk, because we've already made some mistakes, and let's share those so that you can make a whole new list of mistakes, and then we'll learn from you. We'll try just not to make the same mistake twice.
No, thanks so much for that insight. And again, I as we wrap up here, I really just want to thank all of the panelists here. Really not just for sharing your ideas, but these are real world examples and really this cross-sector impact and action. So what's really clear from today's discussion is that rural communities, they're not starting from zero. Again, going back to Dr. Masters, right? It's not innovation, it's really refining and optimizing. So these partnerships, infrastructure, and measurable outcomes, they're already in many places, in many regions. So really, how do we strengthen, align, and scale the work to meet these new expectations and opportunities? So thank you again for everyone who joined us today. We appreciate your partnership and your commitment to advancing rural health. This session was recorded and will be shared with you soon. You will also see a survey we would love for you to participate in about your experience here. And if you're interested in learning more about how Unite Us can support your organization, we ask that you please visit our website and request a demo or schedule a time with our team. So with that being said, thank you all for a great discussion, and hope you all have a great rest of your day, and happy April Fools.